Jaundice is one of the commonest problems encountered when caring for newborn babies. It's mostly harmless, but it is important for any clinician working with newborn babies to have a good understanding of jaundice and be able to identify babies that need a little bit of extra attention and a bit more monitoring and potentially a bit more treatment for their jaundice. I prepared a brief presentation. I hope you'll find it helpful. So I'm Jubal. I'm a neonatologist working at St Vincent's Private, Epworth Freemasons at the Royal Women's Hospital. I'm going to go through what jaundice is, what the physiology of jaundice is, talking a little bit about what causes jaundice, and broadly speaking about the different types of jaundice. Most jaundice is what's called physiological jaundice, which is because of no underlying medical reason for the jaundice. And then I'll talk a little bit about pathological jaundice, which is jaundice that needs a little bit more attention and potentially a bit more management. And then go on to talk about screening for jaundice, the different treatment options, and the follow-up requirements for jaundice. I'm also going to briefly cover an entity called prolonged jaundice, which is jaundice that persists past 2 weeks in term babies and past 3 weeks in preterm babies. So the word jaundice itself comes from the French word jaune, meaning yellow. And so it's the yellow discoloration that is noticed often in the sclera, which is the whites of the eyes of a baby, and also noticed in mucous membranes, the skin, and body fluids. The vast majority of healthy term babies will develop jaundice, and in most babies, jaundice is usually detectable clinically once the bilirubin pigment, which is the pigment that causes the yellow discoloration, is over a level of about 50 to 100. While most babies develop jaundice, only 1 in 20 term babies will require treatment for jaundice. And most of what we'll cover during this presentation is talking about unconjugated jaundice, or sometimes in the past it was referred to as indirect jaundice or unconjugated hyperbilirubinemia. Working with babies, a useful clinical skill to have is to be able to visually inspect a baby and have a sense of whether the jaundice is problematic and requires further investigation or assessment, or whether it seems very benign. And the Kramer's rule are helpful in terms of being able to visually assess a baby's jaundice. So jaundice mostly starts in the face and the eyes, and it's often noticeable there. It's roughly around the 100 micromoles per liter at that point. It then spreads, if it's increasing in value, to the chest and the trunk, and eventually down into the extremities. And the Kramer's rules gives you some rough numbers to have in your head in terms of being able to assess whether the jaundice may be problematic or not. So when it's spreading into the lower legs and arms, it's around the 250 value, and when it's in the extremities and the palms and the soles, it's over 250 and often over 300. So this slide just goes through the way in which the bilirubin pigment is produced and processed and then cleared. And so this is a process that we all go through. So bilirubin is a pigment that is a breakdown product of red blood cells, and particularly the heme part of the red blood cell, which gets broken down into a pigment called unconjugated bilirubin. And unconjugated just refers to the fact that the bilirubin is not water soluble. So unconjugated is not water soluble, and that's why it accumulates in the various tissues in the body. It binds to albumin in the bloodstream and forms the unconjugated bilirubin albumin complex. The liver, with the help of an enzyme, conjugates the bilirubin, which means that it makes it water soluble. And this water soluble bilirubin we're then able to clear out through Most of it's excreted in the stools, some of it in the urine, and some of it's reabsorbed into what's called the enterohepatic circulation. So this is what gives our stool and urine the color that it does. It's because of the bilirubin that's being excreted. You don't need to know a lot of the details of the underlying physiology, but it's useful to have a general sense of what's going on. There is an entity called conjugated hyperbilirubinemia or conjugated jaundice. All results that get sent from the pathology lab will often include unconjugated and conjugated fraction for the total bilirubin value. And the conjugated fraction is usually very small, generally less than 10. And the point of the slide is that sometimes if it's particularly over 25 or 30, it requires further attention, because conjugated jaundice, unlike unconjugated jaundice, is always pathological. So if you're having a significant conjugated jaundice, particularly over 30, it requires further assessment, often involvement of the tertiary teams and a gastroenterologist, and further workup to work out what the underlying cause might be. It's often seen in preterm babies where there's been prolonged periods of TPN exposure. It's also seen in the context of congenital infections or underlying liver disease, and also mechanical obstruction of the bile ducts, which generally clear the processed bilirubin, the conjugated bilirubin being blocked. So biliary atresia and certain syndromes can impair the clearance of the conjugated bilirubin. So it requires further workup, and ursodeoxycholic acid is often used as an agent to help with improving the bile flow. So the commonest jaundice that you will see is physiological jaundice. So most jaundice that is encountered on a day-to-day basis is physiological jaundice that doesn't require any specific management. It often causes a lot of anxiety, but reassurance is appropriate, and it doesn't require direct sunlight or anything else. It generally doesn't appear in the first 24 hours, but appears after the first 24 hours, peaks on day 3 or 4 of life, and then will clear out by 7 to 10 days of life. So the pattern in which jaundice develops and progresses is helpful to be able to distinguish physiological jaundice from pathological jaundice. So jaundice is a concern when it happens too early. So if a baby is visibly jaundiced in the first 24 hours, that's considered a medical emergency. If a baby's jaundice rises too quickly, so in the second day of life, for instance, if the baby becomes increasingly jaundiced quite rapidly or progressively becomes jaundiced over the next few days of life, then that's a red flag. And lastly, there is jaundice that persists. So jaundice that persists past 2 weeks in term babies or past 3 weeks in preterm babies is called prolonged jaundice, and also requires further assessment. And it's always important to remember that infection can also cause jaundice. So if a baby is sleepy and not looking well and jaundiced in the context of that, the jaundice might not be the main reason why the baby is sleepy. It might be because there's infection which is causing the sleepiness and the baby to be unwell. So this slide just demonstrates what the normal pattern of jaundice is in healthy term babies. So this is a study where they just looked at TCB measurements over the first few days of life, and on the x-axis you have age in hours, and on the y-axis is TCB. This is using American units. So TCB of 7 milligrams per deciliter equates to about 110 on the SI units. So that's 7. So usually at about 24 hours of age, on some babies will have a TCB that's over 100, and then it'll continue to rise past the 48-hour time frame up to 72 hours, and around 72 hours is where most babies will hit their peak jaundice level, which is around 170 or 200. If you want to have some rough numbers in your head, and then eventually it'll continue to improve rapidly after that as the feeding improves and the baby gets older. So going back to that point about the pattern of jaundice being important to help distinguish the type of jaundice it is, this is just a slide that demonstrates the various different the patterns of jaundice that you can see. So again, this is age in days on the x-axis and bilirubin levels on the y-axis, and it just shows you, so the usual jaundice, which is physiological jaundice or jaundice that might be related to, say, Kefler hematoma, where there's excessive breakdown of red cells. So bruising and Kefler hematoma just mean there's a excessive load for the liver to work through, would usually appear after the first 24 hours of life, and then rise over the first 3-4 days of life, and then eventually go away. So that's the commonest form of jaundice. The more concerning form of jaundice would be hemolytic jaundice, which is jaundice that appears in the first day of life. So we'd usually be able to detect it clinically over a level of 100, and you'd notice, very rapidly in the first day of life, the baby's looking visually jaundiced, and it continues to rise quite rapidly and requires urgent phototherapy, blood tests to work out what's going on, special care admission, NICU admission. So that's something that's probably one of the main, more concerning jaundice to be aware of. And the other sort of grumbling jaundice, so sometimes you can have a prolonged jaundice that isn't overly concerning in the first few days of life and then persists past 2 weeks of life, which can happen in prematurity, hypothyroidism, and there's an entity called breast milk jaundice, which I'll talk about a little bit later as well. And lastly, you can also get a late rising jaundice where there's underlying liver issues, and this sort of goes back to our point about conjugated issue jaundice and things, which might present a bit later on in life as well. So talking a little bit more about physiological jaundice. Physiological jaundice is the most common time to be jaundiced in a lifetime is in the newborn period, and there's a number of reasons why jaundice happens in babies. It's because they tend to have a higher mass of red blood cells that have a lower lifespan. They have decreased clearance in the liver because of the UGT enzyme that I briefly showed you on one of the slides. It's not as effective in the newborn period, and also they have increased enterohepatic circulation, so slower transit of through the gut, which means that there's less of the clearance of the pigment because through the enterohepatic circulation. So increasing feeds helps with that part as well. And we've covered the pattern of physiological jaundice. So the other common jaundice that you'll see is in the context of poor intake. So sometimes when the breast milk hasn't come in, the baby's dehydrated. It often happens in the first week of life. Can happen just after a baby's discharge, and the maternal child health nurse notice that the baby's jaundiced, dehydrated, losing weight. They're often hyponatremic, and again, it's important to evaluate for sepsis in that context to make sure that it's not sepsis that was the primary reason that the baby was feeding poorly and developed jaundice. I'm just going to go through a few common causes of pathological jaundice. So broadly speaking, pathological jaundice can be broken up into what's called immune mediated and non-immune mediated. So immune mediated means that there are cells that are causing destruction of the red cells. And going back to that slide earlier, it having having a higher breakdown of red cells means that the liver gets overloaded, and which results in that unconjugated jaundice. The commonest pathological jaundice that you'll encounter is what's called ABO incompatibility. So this is jaundice that usually happens where the mother is blood group O and the baby is A or B. And the mother naturally will have antibodies to blood group A and B circulating in her bloodstream. Some of these antibodies go through the placenta into the baby's circulation. The antibodies bind with the baby's A or B blood cells and cause destruction of those blood cells, which causes that buildup of jaundice, the bilirubin pigment. So I think it's particularly important to be aware that if a mother's blood group O, that the underlying cause, if a baby's looking increasingly jaundiced in that period, is that it might be ABO incompatibility. Rhesus incompatibility can cause more severe jaundice, but often gets detected nowadays. So it's rare to encounter it without it being antenatally diagnosed. There are also other antibodies which sometimes cause hemolytic disease. And so whenever there's concern about hemolytic disease, it requires a bit more monitoring of the baby in the newborn period, potentially a bit more aggressive management in the early newborn period. But also it means that the jaundice can grumble on. So they sometimes have a few days in the special care going in and out of phototherapy, and potentially will also need a bit more follow-up in the first few weeks and months of life to make sure that the baby doesn't continue to hemolyze and become anemic. And I've got a little slide about that later on as well. And then there's all the non-immune mediated causes of jaundice. So, trauma, bruising, kefalohematoma, G6PD deficiency. So that's a X-linked condition. So it tends to happen in boys. Girls have two X chromosomes. So generally they'll be carriers because they'll have one X chromosome that's working normally, generally, and it happens in certain ethnic groups more commonly as well. And then there's other less common red cell membrane defects like hereditary spherocytosis, which means that the red cell is more fragile and breaks down more easily, again through a similar mechanism, causing increased levels of unconjugated hyperbilirubinemia. And then there's a few rarer causes of pathological jaundice relating to the UGT enzyme in the liver that causes the conjugation. So Crigler-Najjar, there's a couple of different types of Crigler-Najjar. Phenobarbital is sometimes used as a treatment option. And the other syndrome that sometimes you'll encounter in clinical practice is called Gilbert syndrome or Gilbert syndrome, where there is a mutation in the UGT enzyme, which is often benign, and it causes even adults to have a mildly elevated hyperbilirubinemia, unconjugated hyperbilirubinemia. Congenital hypothyroidism is also a pathological cause. Again, it's uncommon, but it's just something that needs to be assessed for when there's particularly prolonged jaundice. So why is jaundice a problem? So the bilirubin pigment itself, when it's not soluble, can accumulate in the different tissues, but the main tissue that we worry about is the tissues of the brain. And so we all have something called the blood-brain barrier that helps prevent this pigment keeps it out of the brain. But we're not completely sure what the threshold is at which the blood-brain barrier gets overwhelmed and the pigment crosses over into the brain and accumulates in a non-reversible way, which can cause in severe cases long-term disability. So sometimes in the short term you'll see what's called acute bilirubin encephalopathy. So the features are poor feeding, lethargy, abnormal posture, irritability, opisthotonus, which is having rigidity and stiffness. So the neck of babies sometimes in severe cases will be arched backwards and the baby will become quite spastic and rigid, and in rare conditions can cause seizures as well. So the long-term consequence of acute bilirubin encephalopathy is a condition called kernicterus. So it's rare but preventable, and this is the reason why there is so much anxiety about jaundice, and the reason that we manage all the babies where there's concern that they might be developing jaundice. So it can result in deafness, cognitive impairment, seizures, cerebral palsy, and the basal ganglia is the part of the brain that is involved in motor, movement, and so that's where the bilirubin pigment can get deposited. The blood-brain barrier also is affected by conditions such as prematurity, acidosis, asphyxia, hypothermia, and certain medications. So the more unwell a baby might be, the more permeable the blood-brain barrier is going to be. So it's more important in the sicker babies to be more cautious about managing the jaundice a bit more vigorously. Fortunately, we have screening mechanisms. So other than just using those Kramer's rules that we talked about, where a baby is eyeballed to see how significant a jaundice is, TCB measurements are quite effective as a screening tool to be able to assess whether a jaundice requires further evaluation. So TCB is a screening test, and the blood test for measuring the serum bilirubin is the more definitive test. So all management in terms of treatment, so all treatment should be guided by the blood test, and the need for a blood test can be guided by the TCB measurement. So jaundice in the first 24 hours needs urgent evaluation. So often you'd check the SBR, inform the pediatrician. They'll often require aggressive initial phototherapy while the results are awaited, and often SBR, full blood count, DCT at a minimum should be sent away urgently to the pathology to assess what the actual level of jaundice is. After the first 24 hours and the first 24 to 48 hours for term babies over 38 weeks gestation, a TCB of 200 or over 200 should prompt an SBR. And the other value to roughly have memorized, hopefully, is because most babies will get a newborn screening test at 48 hours. So if a baby's looking visually jaundiced around the time of the newborn screening test and a TCB is over 230 for a term baby, or over 190 for a baby that's a late preterm baby, so anyone over 35 weeks but under 37 weeks, that should prompt SBR to ideally be done with the newborn screening test to save the baby an extra heel prick. And around the time of after sort of 3 or 4 days of life, roughly over 290 or over 250 in a late preterm baby should prompt the need for a SBR. So the levels plateau, or the treatment graphs plateau after 96 hours. So if anything over 290 at any point should prompt an SBR. The treatment is straightforward for jaundice in most instances. So only 1 in 20 babies need phototherapy. This is term well babies, and phototherapy itself is visible light. It's not ultraviolet light. It's visible light that through a process of photoisomerization causes the pigment on the skin to become water soluble, and then the body is able to excrete it through the mechanisms that we talked about earlier. So fortunately, there are a few standardized tools that can help determine when phototherapy is required. So the determination for phototherapy is based on the serum bilirubin measurement, and factors such as gestation and the age of the baby also guide the decision for whether treatment is required. There's, broadly speaking, two main guidelines that the decision for phototherapy can be based on. The commonly used guideline is the NICE guideline, and I'm just going to bring that up here. So this is the chart for term babies. There is a chart for every gestation that's available online. The chart has age on the x-axis and the bilirubin measurement on the y-axis. There is a blue line. Above the blue line is considered the phototherapy range, and it's appropriate to start phototherapy when the serum bilirubin measurement plots above the blue line. And the red line is the exchange transfusion range. So if a baby's serum bilirubin is not able to be brought down despite intensive phototherapy and remains above the red line, then exchange transfusion is indicated. The NICE guidelines have a chart for the term gestation, and then every gestation below 37 weeks. It plateaus out at 4 days of age for term babies at 350, and for preterm babies the plateau point is at 72 hours, and it is 10 times the gestation minus 100. So for a 37 weeker it's 270, for a 36 weeker it's 260, for a 35 weeker it's 250, and so on all the way to 24 weeks. And I'm also going to show you the AAP guideline. Again, there are online tools that help you determine where the actual bilirubin level plots. The AAP guideline also similarly has age on the x-axis and the bilirubin measurement on the y-axis, and it takes into consideration a few other risk factors as well to determine whether phototherapy is appropriate. In severe jaundice, the other two main treatment options are using immunoglobulins, and so this is in the context of immune-mediated hemolysis, where there's breakdown of red cells because of immune, say antibodies. And the idea with the immunoglobulin is that the pooled immunoglobulin, when given to the baby, will help mop up all the antibodies that are present, and usually used as a temporizing measure to try and prevent exchange transfusion. So exchange transfusion is something that happens not very commonly nowadays, a few times at the tertiary centers a year, and it is so it's a process of removing the bilirubin from the circulation and removing any antibodies and sensitized red blood cells as well, and as the name indicates, it involves a transfusion of sort of donated blood into the baby to help clear out any bilirubin. It's associated with high morbidity and mortality, so it's done very not very often, and everything that can be done to avoid exchange transfusion should be done. So any baby who's had any jaundice levels in the treatment range will require, in the exchange transfusion range, will require a follow-up hearing screen and neurodevelopmental review. So even if it comes down very rapidly, but at some point was, say, in the 400s, that should require the baby to get ongoing follow-up as well. This slide just goes through the follow-up for hemolytic jaundice. So one of the other important things to recognize is that all babies start off with a hemoglobin level that's around 160, 170, and then over the first sort of 2 months of life, as they transition from fetal circulation, fetal hemoglobin to more adult mature type hemoglobin, will become mildly anemic, and then eventually produce more and more adult type hemoglobin over the first 4 to 6 months of life, and then stabilize. So this graph shows you term babies' hemoglobin levels, which might drop into the early hundreds, and preterm babies or low birth weight babies might drop further, potentially around 80 to 90 at the 2-month mark, and then eventually also recover. So if a baby has hemolytic jaundice, so say ABO incompatibility or other hemolytic disease, there is a risk that they might over this period become become anemic to the extent that it'll compromise their growth. They might get short of breath, and unwell enough that they require a blood transfusion in the first few months of life to prevent what's called that physiological nadir anemia, or anemia that's exaggerated because of hemolysis as well. So briefly going back to prolonged jaundice. So prolonged jaundice is jaundice that persists past 2 weeks of life in term babies, or 21 days in preterm babies. It requires further investigation, and the vast majority of times nothing usually comes back from the investigations, but it's still important to do the investigations because things like abnormal so hypothyroidism, abnormal liver issues, G6PD, and galactosemia can present with prolonged jaundice, and also UTIs sometimes. So usually there's a battery of tests that gets done if a baby is persistently jaundiced past the 2 weeks of life. And there is a diagnosis which is a diagnosis of elimination. So when no other cause is found for prolonged jaundice, it gets put down to breast milk jaundice. So breast milk has some factors that inhibit the UGT enzyme activity and can slow down the clearance of the bilirubin pigment. So despite the baby looking jaundiced, if it's breast milk jaundice, it's not an indication to stop breastfeeding. So the family should still be encouraged to breastfeed, and reassured that the jaundice will eventually clear. And usually the jaundice level is below 200, and generally it'll clear by 3 months or so. And that's all I had for this presentation. I hope you found it helpful.